Uh, 45-year-old female, housewife by occupation, residing in Vallabhgarh, diabetic and hypertensive, presented with chief complaints of frothy urine for last 3 years, anorexia and weight loss for last 6 months. Present history of illness. My patient was apparently all right 3 years back. However, she is non-case of arthritis for last 20 years. She noticed frothy urine, which was intermittent. Along with, she also complained of anorexia, which was insidious in onset, not associated with nausea or vomiting or abdominal pain. That is since last 6 months. And along with this, it was associated with weight loss that was around 7 to 8 kgs in last 6 months. My patient denies of overt hematuria or decrease in urine output or swelling of lower limbs or periorbital puffiness or dyspnea. She also denies of fever or burning micturition, denies of rash all over body or photosensitivity, denies of reddening of eyes, dimness of vision or vision loss, denies history of tingling sensation in lower extremities or nocturnal diarrhea, denies history of jaundice or past history of blood transfusion. My patient was very much concerned about the frothy urine, so she got tested at various centers and she visited local doctor in June 2018. And doctor told that she is leaking protein in the urine, that is around 2600, and it was spot urine. That time, it was said that her other kidney blood reports were normal. My patient started alternative medicine and heavy protein diet after getting advice from one of the homeopathic doctors. After a few months, she again checked her urine protein, which was 600. So she continued homeopathic medicine for further 2 years. That is till March 2020. She did not visit any doctor for 1 year due to COVID pandemic. Recently, she underwent investigation which showed normal renal parameter with some proteinuria on the urine report. So she visited our hospital for her concern. Past history, she gives history of arthritis for last 20 years. She stated that it was rheumatoid arthritis in 2000. She was diagnosed in 2000. She was taking NSAIDs, that was diclofenac and paracetamol, 1 pill per day for joint pain since 1995, and which she continued for 10 years, that is till 2005. Later on, she switched the painkiller to Ultracet after doctor's advice. She used to get RA relapse in winter season every year, for which she used to take Omnacortin for 5 days and she used to stop it by herself. She did not have relapse in last 3 years. After 5 years of diagnosis of rheumatoid arthritis, that is in 2005, she was diagnosed T2DM. Patient said that her blood sugar used to be uncontrolled and she was on oral hypoglycemic agents prescribed by different physicians since last 15 years. Her HbA1c used to fluctuate in between 8 to 11%. Once while she had took insulin around 130 units per day. In 2011, she was diagnosed hypertension, for which she was prescribed Benitoa Trio, and even today she is taking same medicine for hypertension. Since diagnosis of hypertension, many times she got high blood pressure, that is once per year in a range of 160 by 110 millimeter of mercury, for which she always rushed to ER for treatment because she used to get dizziness. ER doctor used to give Lasix as stated by the patient. She is also non-case of hypothyroidism that was diagnosed in 2009. There was no prior hospitalization history other than ER visits for high blood pressure. Personal history, she is mother of 2 children, 1 son and 1 daughter. Last birth was in 2000. There was no history of any abortion in past and no addiction history. Her menstrual history, it was regular and with normal flow. Family history, her mother was non-case of T2DM and her father died at early age due to liver cirrhosis, and her grandma had a rheumatoid arthritis. Drug history, she was on Benitoa Trio that contains benidipine, telmisartan and chlorthalidone. Plus, she used to take metformin, glimepiride plus insulin for diabetes and thyronorm 75 for hypothyroidism.
So is your history complete or you want to ask something else?
Yes, sir. My clinical history is complete.
Your clinical history. So what is your impression on basis of history? Have,
Uh, Sir, based on uh, history, sir, my syndromic diagnosis is nephrotic syndrome, uh, and likely etiology being diabetic kidney disease.
you give any history of swelling over feet or anything like that?
No, sir. As my patient does not give any history of swelling of lower limbs or periorbital puffiness, but she was on diuretics since last many years, and she was also on in between. She used to get diuretics injections also. Sir.
Why she used to get diuretic injections?
As per patient, whenever she used to get high blood pressure, she used to rush to the ER, and that time she used to get diuretics.
So can you diagnose nephrotic syndrome without having swelling or
Uh, Usually, sir, it is a typical presentation. Uh,
how do you
for
define nephrotic syndrome?
sir, nephrotic syndrome defined as a patient present with anasarca plus nephrotic range proteinuria, hyperlipidemia, and lipid hyperlipidemia, and sir,
What is nephrotic range proteinuria?
sir, it is 24-hour proteinuria more than 3.5 gram per day, sir.
So what features of nephrotic syndrome this patient has?
Sir, here in my case, it's a proteinuria uh, plus she was on diuretics. Otherwise, sir, there is no any positive finding towards my syndromic diagnosis.
So you consider that you have made a syndromic diagnosis without any positive thing in the history.
Yes, sir. Two things, sir, because my patient is saying that she is having normal renal functions, and
No, so if patient is having normal renal function, does that mean the patient has nephrotic syndrome?
no, sir, but proteinuria, and she was on diuretics, might
Proteinuria.
be that
So,
may be the reason she doesn't develop swelling.
so some patient comes to you and she says or he says that he has some decrease in urine output. If she takes diuretic, then her urine output increases. The many patients come with this complaint in OPD.
Yes,
So
sir.
would you consider them as having nephrotic syndrome?
No, sir.
How much is the protein? What does the patient knows that how much protein she is passing?
Yes, sir. Actually, sir, June 2018, she stated that it was 2600, sir. That was spot urine, sir. And since last 3 years, recently she checked that was urine report, but she said that it was didn't remember the exact number, but she said there was a proteinuria.
So one time she said she had protein of 2600. Second time she does not remember.
Yes, sir.
So means how this diagnosis is made means I don't know. Ravi, you would like to comment?
हाँ डॉक्टर साहब एक मिनट आई स्टार्ट फ्रॉम द presenting complaints only.
Yes, sir.
So first, actually you have not completed the history. You first summarize the case. You tell me what is the history, what is the summary of your case.
Yes, sir. Sir, my patient, 45-year-old female with long-standing arthritis, with uncontrolled diabetes, hypertension, and hypothyroidism, presented with proteinuria for last 3 years and constitutional symptoms with significant history of weight loss, with significant history of NSAID intake and alternative medicine, sir.
हाँ, तो अब देखो आपने बोला पहले फ्रॉथिंग ऑफ यूरिन. तो
Yes,
सबसे
sir.
पहले बताओ फ्रॉथिंग ऑफ यूरिन क्यों होता है? Why it happens?
Sir, usually when there is a protein leaking in the urine, that time it was a
मतलब
froth.
फ्रॉथिंग क्या है? फ्रॉथ क्या होता है?
Sir, it's a bubbling of the urine
हाँ,
when
तो बबल क्यों बनता है? बबल बस्ट क्यों नहीं करता है? हाँ, तो सरफेस टेंशन है ना ये तो.
yes,
जो आपका लिक्विड जो यूरिन है उसकी सरफेस टेंशन अगर बढ़ जाती है तो बबल्स बनते रहते हैं.
yes, sir.
तो प्रोटीन से भी हो सकता है. सबसे कॉमन
Yes, sir.
पता है इसका क्या रीजन होता है?
Sir,
जो
yes, sir.
WC होती है ना उसमें साबुन पड़ा होता है.
Yes, sir.
तो सबसे कॉमन होता है वो झाग आते हैं यूरिन में साबुन से आते हैं कि साबुन उसमें पड़ा होता है. So
Yes,
just I don't know how much importance you should give to the symptom of frothing in urine.
yes,
ठीक है. Okay, it is defined as one of the symptom in proteinuric disease, but proteinuria में क्या होता है? If it is long standing,
Yes, sir.
then you will develop edema also.
Yes,
Only
sir.
in a very acute setting where the proteinuria just started and within a month the patient is with you with massive proteinuria, you may not have edema. But आपके केस में आप कह रहे हो 2 साल से फ्रॉथिंग था, 2 साल से नेफ्रोटिक सिंड्रोम था, तो एडिमा नहीं आएगा, बड़ा अनलाइकली है.
Sir,
ठीक है.
in usually, sir, in
The
that
argument is जो डायूरेटिक्स ले रहा था, है ना. तो लेट मी
Sir.
डिस्कस इट. तो सेकंड पॉइंट जो था आपने ना वो डिस्कस ही नहीं किया. आपने बोला कि पुअर ओरल इनटेक, एनोरेक्सिया, फिर आपने वेट लॉस बोला, वो आपने डिस्कस ही नहीं किया. व्हाट इज द कॉज ऑफ वेट लॉस, व्हाट इज द कॉज ऑफ एनोरेक्सिया?
Sir, I said that my patient had anorexia. That is since last 6 months. That it was incidence in onset, and it was not associated with sir nausea or vomiting or any abdominal discomfort. Sir.
There
And
was no diarrhea,
no,
altered bowel,
no, sir.
any blood in the stools, any bloody vomiters, ऐसा कुछ तो नहीं था. Abdomen pain significant तो नहीं था.
नहीं sir, she denied of abdominal pain, sir.
अच्छा, और weight loss का क्या लगा आपको?
Sir, it was 7 to 8 kgs in last 6 months, sir. So it's a significant weight loss history, sir.
हाँ, तो उसका क्या आपने हिस्ट्री पूछा?
Sir, as my patient is saying that her renal functions are normal, otherwise I would have considered sir syndromic diagnosis chronic kidney disease.
नहीं, weight loss पे रहो आप. पहले ना देखो, whatever positive finding you get,
yes sir,
you try to analyze it as per the differential diagnosis possible.
Yes sir.
A patient coming to you with weight loss 8 kg over 3 months, let us say, as a significant, that is more than 5% weight loss in 4 months. So then you have to ask, most common is tuberculosis or malignancy.
Yes sir.
Or maybe she has edematous illness and you just gave diuretics and lost weight in that. So
Yes,
did you inquire about the history
Yes.
for malignancy or tuberculosis in this patient?
Yes,
You are
sir.
saying has nephrotic syndrome.
Sir, my patient does not complain of fever, evening rise temperature, and she does not have any contacts in the home, sir.
नहीं, मतलब did she get treat? Sorry.
No, sir. No treatment of tuberculosis in past.
45-year-old male, na?
Female, sir. Female patients.
Female. So history you have taken pertaining to past infections, jaundice or tuberculosis in the past?
Yes, sir. Yes, sir. I told sir there was no history of tuberculosis and no history of jaundice or blood transfusion in past, sir.
So how do you explain this anorexia and weight loss?
Yes, sir.
If a patient is of nephrotic syndrome, why he should have all that?
Sir, sir, sometimes in diabetic kidney disease, patient present with nephrotic range proteinuria without any anasarca, and maybe patient is having, as my patient is saying, it's a normal renal function. Might be the creatinine is in the high normal range, and maybe she is having in a chronic kidney disease. That maybe
so she may be having advanced renal failure. Just say that.
Yes, sir.
She may be in chronic renal failure.
Yes, sir.
She has so many preceding illnesses which can lead to renal failure, you know, rheumatoid arthritis, diabetes, blood pressure, whatnot.
Yes.
And she has anorexia, weight loss for 6 months. So
Yes,
you are keeping diagnosis of nephrotic syndrome as a syndromic diagnosis where the patient does not have any edema.
Yes, sir. But the only thing
you are not keeping a diagnosis of chronic nephritis or CKD, chronic renal failure, है
Sir,
so why is that? Why you keep diagnosis of nephrotic syndrome?
Sir, because sir, as my patient said, my recent blood reports were normal. So I thought that as she's also saying that she's having 2600 of proteinuria.
If I say that she has 2600 protein, but her creatinine in the urine is 2 grams.
Yes, sir.
So then it is not nephrotic.
Sir, even my patient saying that her creatinine is normal. So even if it is in the normal range 1.4, even at 1.4, her eGFR will be sir around 45 ml. So such a significant history of weight loss and anorexia usually comes later in a later stages of the CKD. That's why I haven't kept in the first stage.
So you have to now narrow down and find causes where you will have nephrotic range proteinuria along with weight loss and anorexia.
Yes, sir.
without being in advanced renal failure. So you should have differential. है ना?
Yes, sir. Yes, sir.
Patient has a rheumatoid arthritis, patient has
Yes.
diabetes. So what could
Yes.
be other causes, anorexia, weight loss? So that you should actually put in your differential.
Yes, sir.
Dr. Sham?
Yeah, no, see, the thing is very strange. You are basing everything. So, first is your syndromic diagnosis is wrong. So,
Yes.
nephrotic syndrome, there is a difference between nephrotic syndrome and nephrotic range proteinuria. There can be
Yes.
nephrotic range proteinuria in many diseases, IgA nephropathy, many other diseases in which there can be proteinuria maybe more than 3 gram, but person does not present with nephrotic syndrome.
Yes, sir.
Nephrotic syndrome presentation means person has protein, apart from significant proteinuria, hypoalbuminemia, and edema. And that is a hallmark feature of nephrotic syndrome.
Yes, sir.
Secondly, there is no coordination between your history and your diagnosis. On the one hand, you are saying that patient has nephrotic syndrome and has normal renal function. Secondly, you are saying the patient has significant weight loss, patient has uncontrolled diabetes, patient has uncontrolled hypertension, which all point to the diagnosis of chronic kidney disease. So if you are not sure, because you have to explain,
Yes,
you
sir.
can't just say the patient told me this thing and
No,
that
sir.
I am considered. So whatever patient told you, you have not seen the report.
Yes, sir.
Okay, so you should make a diagnosis of chronic kidney disease based on our symptoms and the long-standing diabetes, long-standing rheumatoid arthritis, uncontrolled hypertension.
Yes,
Okay,
sir.
history of weight loss, history of anorexia. There's no other things which are suggestive of any other disorder like tuberculosis or malignancy or chronic liver disease, other diseases which are likely to cause these things.
Yes, sir.
So means just patient said something. Patient might be, she might not be told by her doctor or the relative that she has advanced kidney disease.
Yes, sir.
Sometimes patients are not aware. Their relatives don't tell them.
Yes, sir.
Doctors are not. Doctor are sometimes advised by the relative, told by the relative not to reveal the diagnosis to the patient.
Yes, sir.
But you should be able to explain the diagnosis you made. You are making a diagnosis which you are not able to defend. You are telling the symptom which you are not able to make diagnosis. So that is not the right thing. I think to go to examination. Let us see anything in the examination, and then you want to change your diagnosis. No, think before you make a diagnosis.
Sir,
How
the
you are going to defend the diagnosis.
sir, I have because nephrotic because the patient was on diuretics. That's why I have kept that.
Patient
And
was on diuretic, that is not an excuse for that.
yes, sir.
Patient never had edema.
Yes, sir.
Being on diuretic does not tell that patient is a nephrotic syndrome.
Yes, sir. Sir, second, I have kept chronic kidney disease. Sir, that might be because of,
Tell the examination.
Examination.
okay, sir. Sir, on general examination, my patient was conscious, alert, cooperative. Her BMI is 22.05. Her pulse was 80 per minute, regular, symmetrical in both hands, without radial or radiofemoral delay. All the peripheral pulses are palpable. Her blood pressure was 130 by 80 millimeter of mercury in lying position in left arm, and it was 120 by 80 millimeter in standing position. Respiratory rate was 18 per minute, thoraco-abdominal. My patient was afebrile. There was a pellar, and there was no icterus, clubbing, lymphadenopathy, or a pedal edema. My patient's JVP was normal. There was no any skin changes all over body. Absence of any sternal tenderness. This was the general examination. On physical examination,
Joint deformity.
sir, there was actually I have kept in the musculoskeletal system. That's why there was no. Yes, sir. Yes, sir. Yes, sir. Sir, on physical examination on cardiovascular system, there was no precordial deformity, no thrill-on palpation. The apex beat was in fifth intercostal space, half-inch medial to the midclavicular line. Heart sounds were normal, no pericardial drop. And respiratory system, trachea was in central position, bilateral symmetrical movement of lungs with resonant note on the percussion on both the lung fields. On auscultation, bilateral vesicular breath sounds and equal air entry. No added sound on auscultation. On CNS examination, the higher functions with speech were normal, no focal neurological deficit. On sensory system examination, there was no signs of any peripheral neuropathy. On abdominal examination, the abdomen was not distended with normal umbilicus, no shifting dullness. There was a hepatomegaly. The liver span was around 2 finger below subcostal margin with smooth surface, no other organomegaly.
How much is
Muscle,
liver this thing below costal margin?
so 2 finger below subcostal margin, sir.
Okay.
On musculoskeletal system, there was no swelling or tenderness of the joint, or there was no joint deformity, sir. Sir, on fundus examination, there was no signs of any diabetic retinopathy, sir.
No signs of diabetic retinopathy. 15
Yes.
years of diabetes, uncontrolled hypertension, urine.
Sir, on urine examination done at bedside, it was protein was 3 plus. Sir, RBCs were nil, sugar was 2 plus. There was no cast or crystal on microscopic examination, sir.
So what is your diagnosis now?
Sir, based on sir findings, sir, my patient is having proteinuria plus
No, I am asking diagnosis.
sir, my provisional diagnosis being nephrotic syndrome with etiology being sir diabetic
तो
kidney.
डॉक्टर साहब आपको कुछ भी नहीं मिला नेफ्रोटिक का एग्जामिनेशन में?
Yes,
ना
sir.
तो आपको कोई डलनेस मिली, ना साइटिस मिली, ना आपको कोई एडिमा
Yes.
मिली है, ना नेल चेंजेस है, स्किन चेंजेस हैं, तो कैसे आप नेफ्रोटिक बना सकते हो? कुछ भी नहीं मिला. There is nothing to support your diagnosis in examination, है ना?
Only proteinuria, sir. Nephrotic.
No,
Like,
that is.
yes, sir.
So that is not quantitative proteinuria. That
Yes,
is a
sir.
spin.
Yes.
You don't know whether it is 2 gram or 3 gram or 1 gram. You don't know.
Yes,
It's a
sir.
concentrated sample or it's a dilute sample. How do you know?
Yes, sir.
What was the specific gravity?
Sir, it was sir 1.010, sir.
1.010. What does that mean?
Sir, likely concentrated solution.
No, see.
Sorry, dilution. Sorry.
The thing is, so how do you explain if the patient has nephrotic syndrome and you want to make it nephrotic syndrome because of what?
Sir, it's significant long-standing history of type 2 diabetes mellitus, but again there is no diabetic retinopathy. So still,
डॉक्टर
sir,
नेफ्रोटिक सिंड्रोम छोड़ दो, नहीं बनेगा इसमें.
okay,
Leave it. उसको अपने माइंड से निकालो और ट्राई टू एनालाइज द थिंग्स. अब आप दूसरा डायग्नोसिस अपना फर्स्ट क्या रखना चाहते हो? री अटेम्प्ट इट, है ना? नेफ्रोटिक सिंड्रोम नहीं बन सकता विद दिस
okay,
हिस्ट्री.
sir. I will keep chronic kidney disease as a syndromic diagnosis with etiology being diabetic kidney disease as a cause. Sir.
Any other differential diagnosis apart from CKD, diabetic nephropathy?
Sir, yes, sir. CK, other than the other cause of CKD being, sir, maybe because of long-standing history of analgesic use and chronic analgesic nephropathy, sir.
Any other?
Sir, long-standing history of RA that.
Yes, now you are making some sense. So there are 3 things in this patient. She is long-standing diabetic, more than 10 years. Then she has chronic rheumatoid arthritis, but physical examination is normal, which is actually very suspicious that
Only,
this patient really had rheumatoid arthritis or some
yes, sir.
changes, just joint pain. And third is
Yes,
the
sir.
analgesic history of the analgesic intake, which was long-standing, which can again cause chronic kidney disease and kidney. So one thing is sure, if you want to defend the diagnosis of chronic this your finding, your history
Yes,
of weight loss or anorexia and no other systemic illness, then you
yes,
have to make a diagnosis of chronic kidney disease, that too of advanced CKD, like CKD stage 4 or 5, like that.
yes, sir. Yes, sir.
Otherwise,
But yes,
difficult
sir.
to
Sir, I haven't kept that because of my patient said that there was a normal renal function. That's the only, sir.
No. Patient
Yes.
says is not important.
Okay,
Patient
sir.
does not
Okay,
know
sir.
what is the creatinine value. What does the patient say about that?
she said in normal range, so I consider maybe 1.4. So even at 1.
How do you consider it 1.2? Either you know it or you don't know it. How do you consider that?
No sir, normal range sir, she said in normal range, so sir I thought
Yeah, ये तो
okay
बहुत.
sir.
This is see. So then defend why this patient has weight loss and anorexia. Tell me.
Yes sir.
Tell me. So you must have thought something. You are going to present this case. You are prepared for this case. How do you defend this that patient has weight loss anorexia?
So maybe sir,
There is no ascites. There is a no positive finding in chest exam or abdominal examination or anything else. So how do
yes sir.
you defend that symptoms? She's lying.
No sir, maybe because of long standing RA patient, amyloidosis one of the DD sir.
Amyloidosis without any edema with severe
Sir,
hypertension.
sir, that yes, sir.
What
That
was the
is,
blood pressure of patient?
sir. It was sir 130 by 80, sir.
Amyloidosis with long-standing nephrotic syndrome, you will never have more than 100 BP.
Yes, sir. RA, sir. Long standing RA.
Okay, now let us come down to the things which are there in your case. It is an interesting case. Lot of findings are there. Patient had rheumatoid arthritis, you said. Though I'm
Yes,
not clear what immunosuppression she took for it or how long.
yes, sir. Sir, I said that patient used to get relapse once in a year, and she used to take sir omnacotil herself, sir, and she used to stop it by within 5 days.
Rheumatoid arthritis is getting treated by 5 days of steroid. It is not
Sir,
rheumatoid arthritis.
sir, that's what patient said, and sir, I am not saying it was rheumatoid arthritis. My patient said it was rheumatoid arthritis. That's why, sir,
What history you took to confirm
yes,
that
sir.
it is rheumatoid arthritis?
Sir, she given a typical history of morning stiffness, which used to get relieved on as day passes, and she also given a history that she was treated with
No.
methotrexate. Yes, sir.
You first have to ask how much time did the patient, the pain relieve in how much time, and how severe was the limitation of movement or pain. Sometimes there are arthralgia, sometimes
Yes,
there
sir.
is arthritis. So did
Yes.
you differentiate whether there is joint swelling, redness,
Yes, sir.
limitation of movement?
She said, sir, there was a swelling as well as there was a joint pain, and it was particular in morning stiffness was much more, and as she used to her daily activity, it used to get relieved, sir. And this is since sir last 1995, and later on in 2000 she was diagnosed with RA, and she also said me that she got RA factor positive. Otherwise, I have said sir that was arthritis, but
For how much time?
yes, sir. She was used for 6 months. She got sir methotrexate and hydroxychloroquine, sir. But after that, she has stopped all medicine. And again, sir, I am against the diagnosis
I'm
because
convinced
patient.
that it is RA. I'm convinced. Now, second question comes is that how does RA affect the kidney?
Uh, sir, long-standing RA around 18 to 20 years may cause because of chronic inflammatory arthritis may cause amyloidosis, and that may cause nephrotic syndrome, renal manifestation of amyloidosis. Other cause being sir immune complex mediated GN sir, because of RA sir. That
कौन
is
सा होता
very
है
rare,
immune
very
complex?
rare sir, very rare
कौन सा
sir.
होता है?
Sir,
भाई आरए में रीनल इन्वॉल्वमेंट क्या क्या होती है? ग्लाउंडुलर बताओ, इंटरस्टिशियल बताओ, वेस्कुलर बताओ, एक एक करके सारे बताओ.
sir,
मेम्ब्रेनस नेफ्राइटिस होती है, इसमें मेम्ब्रेनस हो सकती है.
sir, membranous is one of the secondary cause of membranous is rheumatoid arthritis, sir.
है ना?
Yes, sir.
मेम्ब्रेनस हो जाती है, अमाइलॉइड हो
Yes.
जाता है, क्रॉनिक
Yes, sir.
इंटरस्टिशियल नेफ्राइटिस होती है,
Because
तीन
of renal.
वेस्कुलाइटिस
Yes.
होती है, आपको पता है?
Yes,
There
sir.
are two types of renal vasculitis which occur because of rheumatoid arthritis, है ना? दोनों डिफरेंट हैं.
Yes, sir.
अब जो डिटेल में आप पढ़ के आया करो जब आते हो ना, रीनल इन्वॉल्वमेंट इन आरए इज स्टैंडर्ड क्वेश्चन.
Yes, sir.
ठीक है. फिर सेकंड आपके पास है, आपने एक वर्ड यूज कर लिया, एनाल्जेसिक नेफ्रोपैथी है, क्रॉनिक.
Yes, sir.
पहली बात तो एनाल्जेसिक नेफ्रोपैथी को क्रॉनिक कहते नहीं है, वो तो एनाल्जेसिक नेफ्रोपैथी होती है ना?
Sir, I said, sir, I said chronic kidney disease may be secondary to analgesic nephropathy.
अब ये बताओ व्हाट इज एनाल्जेसिक नेफ्रोपैथी?
Sir, analgesic nephropathy when patient took Earlier, sir, there was the patient used to take phenacetin plus aspirin plus caffeine combination. The definition was 1 gram per day for continuous 2 years. Then they used to get chronic tubulointerstitial kidney disease, sir. And
देखिए, analgesic nephropathy is a specific disease entity.
yes,
It is not a NSAID associated chronic kidney disease. Okay.
yes, okay,
It is caused by use of mixture of 2-3 and NSAIDs, namely
yes,
phenacetin, diagnosed in Second World War. It is a pre-malignant condition, very important.
okay,
Other conditions are not pre-malignant. If you have NSAID associated chronic interstitial nephritis, it's not a pre-malignant condition, but analgesic nephropathy is pre-malignant condition. Okay.
okay, sir.
So it's a specific disease entity. You cannot use the word analgesic nephropathy for NSAID associated AKI or CKD. Okay. तो आप ये ध्यान रखो पहले NSAID ये इसका जो है. How does NSAID affect kidney?
Sir, usually it blunt the renal autoregulation.
How?
So, sir, it actually because of inhibition of prostaglandin synthesis, inhibition, there is a.
What is the site of inhibition? In
Sir,
the
it's in the afferent artery also.
And it is 3-site action.
Yes, sir. Afferent arterioles and the at the
ascending loop of Henle and
yes,
cortical collecting duct. It is 3-site action. Prostaglandin inhibition occurs and causes the problems, tubulopathy, है ना? तो एक आपको एकदम से क्लियर होनी चाहिए चीजें.
okay,
तो आपके पास NSAIDs आ गए, लॉन्ग स्टैंडिंग, आपके पास RA आ गया. तीसरा आपने बोला डायबिटीज.
yes,
The diabetic nephropathy, तो you must have attended lot of classes, हैं?
yes, sir.
And diabetic nephropathy. So अब now out of these three, which one you feel is going on?
Hello.
Which one will you
Yes, sir.
consider as a first diagnosis? No, so there are 3 differential diagnoses. So which one will you consider as number 1, 2, and 3?
Sir, I will keep diabetic kidney disease as a first. And
Diabetic kidney disease without diabetic retinopathy.
yes, sir, that is
How
against.
common is the diabetic kidney disease, diabetic nephropathy without retinopathy?
Sir, around 15 to 30% patient of T2DM may got diabetic nephropathy without diabetic retinopathy, sir.
No, these patients can have proteinuria without the without being diabetic being the cause of proteinuria. Is that so, or it's a diabetic nephropathy without diabetic retinopathy?
No, sir. No diabetic retinopathy. Still, patients get a diabetic nephropathy, sir.
But most of the patient will not develop. Most of the patient who develop diabetic nephropathy will have diabetic retinopathy.
Yes.
So this point does not favor diabetic nephropathy diagnosis. So what favors the diagnosis of diabetic nephropathy in this case?
Sir, long-standing history plus uncontrolled hyperglycemia plus hypertension. So these are the risk factor which favors the diabetic kidney disease.
So can patient have advanced diabetic kidney disease without any swelling or any thing like that?
Sir,
Because usually patient with diabetic kidney disease who reach to the advanced stage would usually have the edema and all that.
yes, sir.
What are the stages of diabetic nephropathy?
Sir, there are 5 stages of diabetic kidney disease histologically. That first two are, sir, first one is the hyperfiltration stage of hyperfiltration, then silent stage, that are both are preclinical. Third one is incipient stage of.
Hyperfiltration and then silent stage means?
Sir, first one is stage of hyperfiltration. Second one is, sir.
Sir, how many years of diabetes?
Sir, which one, sir?
How many years after diabetes?
This first stage one, sir. After, sir, 5 years of diabetes, sir.
When can you see the earliest changes of diabetes in kidney biopsies? So earliest would be histological changes, no?
Yes, sir. That is glomerular basement thickening, sir. That is stage one, sir.
What time of the diabetes they can appear?
Sir, usually maybe at the, sir, 5 years. Sir, exact I don't know, sir.
Okay, then hyperfiltration. So what happens in hyperfiltration?
Sir, because of the uncontrolled hyperglycemia, there is a increase in the single nephron GFR. So,
Okay, then
sir, third stage is, sir, there is a microalbuminuria, that is the incipient stage nephropathy. Then the fourth one is overt nephropathy, that is, and for fifth one is the advanced glomerulosclerosis, sir, the ESRD, sir.
is there any timeline for these? That is what I was asking.
Yes, sir. Usually, sir, patient get overt nephropathy within 15 to 20 years of long periods, duration of T2. Sir.
Okay, so this time duration is in favor of the diabetic kidney disease, but because this patient does not have any other thing
Yes,
like edema or patient
nephro-
diabetic
ret-
retinopathy,
retinopathy.
you like to consider some other
Yes,
diagnosis.
sir. Yes, sir. Because of long-standing RA associated uh,
But this patient either
diabetes.
means was in remission for rheumatoid arthritis because she did not take treatment for long. So probably this rheumatoid arthritis either it improved after the initial treatment or she did
Sir,
not have any active rheumatoid arthritis. She has not taken anything for last 15, 20 years.
maybe,
How does
sir, maybe, sir, other uh, maybe it was not a rheumatoid arthritis. Maybe patient may having a,
one thing you were saying patient that rheumatoid arthritis,
sir, that is said by patients, and sir, because there is no joint deformity even after 20 years. That's why I am saying that it might
do
be
you
not
consider
the.
this as a differential diagnosis or not as a differential diagnosis of chronic kidney disease or no?
Sir, because of long-standing chronic inflammatory arthritis, maybe
Well,
secondary membranous nephropathy, sir, because there is absence of a diabetic, means non-diabetic kidney disease, sir.
Ravi,
Okay, you tell me, did the patient have nocturia? Did
No,
you
sir.
ask history of
Yes,
nocturia?
yes, sir. There was no
And how
issue of
did you
no.
ask? How much time? How many time he get
Yes,
up
sir.
in the night
Sir,
to pass urine?
sir, only 1 to 2 times, sir.
No, but two times actually is abnormal. Nobody gets up in sleep two times to pass urine. Okay. So if somebody says I used to pass urine twice in the night, get up from sleep, so that means he has some kidney disease, है ना? So
Sir,
why I'm
maybe,
asking
sir,
you
because of uncontrolled hyperglycemia,
that,
because
yeah,
he
that
said,
can be there. That can be there. So I'm asking you is that the patients, if you want to, ask for, you have to try to judge that if the patient had renal dysfunction or renal disease, how long time back she had that. So
yes,
because you have given history of 2 years of proteinuria
yes, sir.
and some 6 month history of anorexia, so we don't know whether what was before the two years, or whether even those 2 years, the initial 1 year, was there any kidney disease, we are not sure. So you should ask other history to see whether patient has a chronic kidney disease. So what are those other histories?
sir.
What is the age of the lady?
Sir, it's a 41. Sir, till now, sir, what I got is, sir, my patient is having proteinuria and long-standing diabetic, but still patient does not have diabetic retinopathy. So again,
No, no,
sir,
no, no. My question is different. Na? I'm asking you that what other history you will ask for diagnosing that patient has a chronic kidney disease. She's a lady of
yes,
40
sir. Sir,
years.
already, sir, she told some constitutional symptoms plus weight loss that is in favor of chronic kidney
But there
disease.
are some two, three specific things you should
Yes,
learn
sir.
to ask. One is menstrual history, whether there is a menstrual irregularity,
No, sir.
excessive bleeding, intermittent spotting. Did
She
she have
said,
them?
sir, no, sir. Sir, her menstrual is regular flow with regular cycle, sir.
Okay, that is one
Normal
thing.
flow. Yes,
So
sir.
this goes against chronic kidney disease. You know, if patient has a advanced chronic kidney disease, CKD 4-5, she will have a menstrual some problems.
Yes, sir.
And second is nocturia. If patient has a long-standing nocturia, then you can say, okay, you probably started having a chronic disease from that time. So did you specifically ask the history of nocturia, whether she gets it twice in the night, then from how long? 1 year, 2 year, 5 year? Because these are early
Yes,
symptoms.
sir. Since many years she is passing 1 to 2 times per, sir. Around means 10 years since
So
last ten
maybe she
years.
has a
Yes, sir.
chronic kidney disease, my dear. That is what I'm saying. So this points in favor of a chronic interstitial pathology. You know,
Yes,
when tubules are involved, whether chronic or acute, first symptom is polyuria,
yes.
nocturia. That is the first sign of tubular pathology.
So
So
that
if so maybe
yes,
then you can narrow down your differential that it is a chronic kidney disease, which is interstitial type of disease, not a glomerular type of disease.
yes,
Okay. So whenever you try to analyze a kidney failure, you have to point your questions toward vascular disease, glomerular disease, interstitial disease, or a obstructive nephropathy. So
yes,
try to point your questions in this. Look, in nephrology, diagnosis can only be made by good history. There is no other way. You
yes, sir.
cannot, history will give you diagnosis, otherwise you will never make the diagnosis. Hai na? So
Yes,
you have to point your questions to what is the segment of the kidney which is predominantly getting involved. It is not glomerulus, as you were saying, because there is no edema.
yes.
Hai na? It is not glomerulus because there is no out of the way hypertension. Maybe one drug controlled hypertension you are saying, na?
No, sir. Sir, three drugs, sir.
Acha, three drugs.
Benidipine, telmisartan, and sir chlorthalidone, sir.
Okay, so
Since
significant
yes,
hypertension. So these are the way you have to analyze the pathology. Okay.
yes,
So अब आपको डॉक्टर श्याम और क्या डिस्कस करें इनसे या डायग्नोसिस पूछें अब इन्वेस्टिगेशन
Yes, the thing
इन्वेस्टिगेशन
is that if the history, because you have to, the history and the diagnosis does not match. So on the history, it looks like the patient either has chronic kidney disease which is advanced, or the patient has some other disease like malignancy or tuberculosis or chronic liver disease or something else which is causing this significant weight loss. Unless the patient is doing some diet restrictions or something, this does not explain your history and diagnosis based on that. So there is the poor coordinations. And secondly, if you say that a patient has more than 15 years of diabetes, there is no retinopathy, there is no neuropathy, there is nothing, means that is, there's something amiss in your history or your examination. Because see, once you go nowadays, I don't know, but if you the examiner is there and if he's seeing the patient, if he sees some positive finding and you have missed those, then it is going to be difficult, because this does not explain, because your history wise it looks like the patient has some mild kidney disease. And maybe it's very difficult in my opinion to find whether it's a glomerular or interstitial, unless the, because patient is on diuretic. So if there is a kidney disease is not advanced with mild kidney disease stage 3, sometimes there may not be any edema, but patient has hypertension. And hypertension developed after the 5 6 years of diabetes. So most likely it's the diabetic nephropathy which caused the hypertension in this patient. She was only she is on triple drug and we don't know blood pressure control. So it's difficult to, without physically seeing the patient, there is something is not correlating. You should always whatever history you take and diagnosis you make, should be some way of explaining it, and there is always some way of explaining it. You just can't have a in coordination between two, because there is an explanation. There may be some problem in your history taking or your interpretation. But this is totally different things which are going on. So you can't make a diagnosis of nephrotic syndrome at presentation without any history of any edema, any anasarca. That's how we make a diagnosis of the nephrotic syndrome.
And that too 2 years of frothing.
Yeah. So how you make, so your first diagnosis is wrong. From history wise, your diagnosis looks like advanced chronic kidney disease. But then there are other things which do not support, we don't know.
Let us see the investigation.
So somebody has investigations. Yeah, I was asking that.
Sir, sir, on blood investigation, sir, complete hemogram, the hemoglobin was 9.9, total count was 9,000, platelet count was 250,000, and TLC when in normal range, sir. Renal functions, creatinine was 0.9, urea was 17, sodium 135, potassium 4.02, and 24-hour urine protein is 8.7 gram per day. Her liver function test, sir, she had mild transaminitis, sir, 163 SUOT, 206 SGPT, and Ag ratio is 0.48, sir. Sir, lipid profile, the total cholesterol was, sir, 280, and TG was, sir, 250, sir. And her HbA1c is 12.3, sir. And on radiological examination, sir, USG showed,
No, you would not like to ask serum protein albumin,
uh,
calcium?
sir, yes, sir.
You are making a diagnosis of nephrotic syndrome. You don't
Sir,
want.
these are actually, sir, initially, I'm coming to, sir, that.
No, you are going to now ultrasound and all that.
Sir, I said, sir, albumin is, sir, 2.9, globulin is 6.29, the Ag ratio was 0.48, sir. Sir, calcium was 8.15, phosphate,
Total protein, doctor.
total, sir, total protein 9.19, sir.
Or globulin 6.
Globulin is 6.29, sir.
तो myeloma बना रहे हो आप.
Sir, but calcium is, sir, 8.15, and
हाँ.
creatinine is 0.9, sir. Sir, patient is having long-standing RA, might be hypergammaglobulinemia,
Can be in that also.
and
A chronic liver disease may be also you can have this picture.
yes, sir, a patient is having, sir, transaminitis, and
But
having,
then
and
in that
having,
total protein should be less actually. Okay, then what
yes,
else? Tell me.
sir, viral marker were, sir, including HBS antigen, anti-HCV antibody, and HIV1 and 2 were negative, sir. And sir, on radiological examination, USG wall abdomen, there was, sir, right kidney was 11 centimeter, left kidney was 10.2 centimeter, mildly raised ego texture with maintained CMD. There was no ascites, and there was a hepatomegaly with poor sequogenicity. ISBR were normal, sir. Chest X-ray was absolutely normal, and so these were the routine investigations, sir.
So what else would you like to do with this patient thing, all these investigation?
Sir,
What is your differential diagnosis now?
yes, sir. Considering this, sir, my patient is having anemia and normal renal function with nephrotic range proteinuria, massive proteinuria, 8.7 gram, and with background of autoimmune etiology, uh, uh, and without any in my, I would like to do, sir, some serological investigations, serology.
बताओ क्या करोगे?
Sir, I would advise for ANA by IFA, sir, and so it shall I, sir, say what was the report? Sir?
Hey, ANA, what else? ANA is
Sir, ANA, and I would like to give C3, C4, sir, complements and the with significant nephrotic range proteinuria. I would also like to send some anti-plateau antibody, sir.
anything else?
Sir, sir, after getting ANA and C3, C4, I would like to further investigate the patient, sir.
Not before that. So can you explain why this patient with, if suppose she has SLE or some other glomerular disease, why she would have weight loss?
Sir, my patient is having transaminitis, sir. So might be she is having some hepatitis, maybe autoimmune hepatitis.
Autoimmune hepatitis. That can cause such significant weight loss without any.
No, not significant weight loss, but still anorexia can be explained, and maybe, sir, because of
So what is ANA and other complement levels?
sir, the ANA was, sir, positive with fine speckled pattern. It was 1:1000, sir. Strongly positive, sir. And sir, C3 was in normal range. It was 180 and high normal range, and C4 was 23.40, sir.
So what next?
Sir, I would like to further investigation with anti-double stranded DNA and sir, ENA profile, sir. For as
So
my
do you
patient,
suspect if the complement levels are normal, then the patient can have SLE?
sir, complement level will tell me the disease activity, ongoing disease, but still, sir, will order.
So what is DSDNA?
Sir, it was positive, sir. It was 65.20. It was done by the ELISA method. It was more than 2 reference range, sir. And yes, sir. Inner, sir, ENA profile, Smith antigen was also positive, sir. 143.5, sir.
So now what is your diagnosis now with all these finding? You have a ANA positive,
Yes, sir.
C is normal. Patient has a nephrotic range protein, nephrotic syndrome.
Yes, sir.
Cholesterol is high.
Yes, sir.
So now what are the possibilities?
Sir, possibilities being the nephrotic syndrome may be secondary to autoimmune etiology. The first secondary membranous nephropathy will keep lupus nephritis as a first DD, sir. And sir, because sir, Smith antigen and double-stranded DNA were both are positive, so that's why, sir, more specific. And my patient is not having, sir, deformity over so a long period, so likely my patient has misdiagnosed of RA, and maybe she is having underlying.
What are the connective tissue disorder? Tell their names.
Sir, rheumatoid arthritis, SLE, scleroderma, systemic sclerosis, mixed connective tissue disease. Yeah, sir, then this all the vasculitis, sir. Small
Sjogren syndrome.
Sjogren syndrome, yes, sir.
Okay, so out of this, out of our initial diagnosis, NSAID associated problem, diabetic nephropathy, and rheumatoid arthritis related problems. So you feel it is going with some rheumatoid arthritis related or connective tissue problems, है ना?
Yes, sir.
It is not now diabetic nephropathy or NSAID associated. So you've narrowed down with the help of investigation.
Yes, sir.
Which next question comes is which connective tissue disorder?
Sir, I would like to keep lupus as a first, sir, because there is a
ANA is positive. ANA is positive.
no,
But
sir, not ANA. Double-stranded DNA and Smith antigen is positive.
Okay. Okay. So then what other, can you have some connective tissue where you can have lupus along with some other disorder?
Yes, sir. Mixed connective tissue disease, but usually, sir, in mixed connective tissue disease, renal involvement is rare, sir.
What test you do for mixed connective tissue disorder?
Sir, RNP, sir.
U1 RLP.
U1 RNP, sir.
U1 RLP. So, and did you repeat rheumatoid arthritis in the RA factor in this?
Sir, RA factor was earlier positive, sir. We haven't repeated, sir.
Did you do anti-CCP or RA in this? No?
No, sir. Anti-CCP,
Okay.
I haven't.
Okay. So you have narrowed down, probably it is a lupus. Huh?
It
Yes,
is a
sir.
So,
surprising. I just thinking this
yeah.
patient has joint pain 20 years back. She has taken treatment for 6 months, and for last 20 years she did not have any other features. Last 20 years a long time. No rashes, no photosensitivity, no oral ulcers, no history of miscarriages.
Yes, sir.
So there's something is hard
Okay.
to explain. 20 years, it's not a 2 or 3 years of the SLE that some of the symptom will appear, some will not come, because the investigation they favor a diagnosis of SLE, but history wise I think probably there should have been at least some. There's nothing in the hematological
I think by
examination.
history taking, he must be missing something, I think, because there must have been some positive findings if it is a long-standing illness like that. So maybe
3 years
you are.
of less, yeah, so 5-10 years the
Sir, my
symptom.
patient does not have any skin changes. There was no alopecia. There was no, sir, any skin deformity, any joint deformity, or any,
No,
sir,
joint
any.
deformity is fine. I'm just asking skin symptoms, some rashes, some photosensitivity.
Yes, sir.
Combination
Sir,
of two or more.
चलो ठीक है. So have you done kidney biopsy in this patient?
yes, sir.
What are the findings?
Sir, uh, there was, sir, one linear tissue that was 0.5 centimeter in formalin for light microscopy. It containing, sir, up to 5 glomeruli, uh, 3 globally sclerosed, and the remaining glomeruli appear enlarged and reveal diffuse thickening of capillaries, which show membrane texture alteration and intramembranous mottling, discernible in a silver methamine stain section, and few glomeruli reveal segmental increase in mesangial matrix. There was a 15 to 20% of IPTA. Artery shows mild medial thickening, while arterioles reveal focal hydinosis lesions. On immunofluorescence, the tissue was containing 8 glomeruli following immunostaining pattern. The IgA was negative, IgG was 2 plus, it was granular, IgG1 was 2 plus granular, IgG2 was 1 plus granular, G3 was negative, G4 was 2 plus, capillary wall segmental granular, IgM was negative, C3 was trace, C1q was trace 1 plus, capillary wall segmental and granular. Kappa light chain and lambda light chain both were 2 plus, capillary wall segmental granular. And anti-PLA2 and thrombospondin were negative along the glomerular capillary walls.
So what is the diagnosis?
Sir, they have membranous pattern glomerulopathy with mild IPTA, and to they have suggested to look for the secondary causes of membranous nephropathy. Sir, here IgA is negative and IgM negative. So, but C1q is positive, sir. So it is again not a full house, but still C1q is positive. So
Anything on the immunofluorescence by which you can make whether it is a primary or secondary?
primary, yes, sir. Sir, mesangial deposition of IgG2 will give us the secondary causes of membranous, sir. Will more signify secondary causes of membranous.
And primary, which IgG is positive?
Sir, IgG for Sir, don't know, sir.
So IgG 1 and 2 then favor the secondary, and probably 3 is favor the primary. So secondary membranous would be the diagnosis. So I think it's okay, because I think Ravi, anything else? There's no point in discussing the treatment, I think.
Yeah, I think, but this certainly peculiar C3 is normal. Generally, we would expect in SLE should be low if there's active disease. There are no systemic symptoms. Did you apply the criteria? What are the criteria to diagnose SLE?
Yes, sir. Slice criteria, sir. There was no any skin lesions, but only normocytic normochromic anemia. But there is no any features of hemolytic anemia. Only immunological markers were strongly giving the.
Does it satisfy the criteria?
Answer.
SLE?
Answer renal proteinuria, sir. That is more than 500.
So if there is I think there is some change in classification. If you have this immunological markers and the even the renal involvement, then it fulfill the criteria of SLE.
More
so
than
patient has membranous cysting, sometimes the complement can be normal in this patient. So that might be the reason, but obviously this patient has membranous lupus, and so the diagnosis is not. So do you, what are the latest criteria? Do you remember for
for what?
diagnosis of SLE?
Sir, slick criteria, sir, for diagnosis, that is more than 4 out of uh, one of the 2 among the immunological criteria, and more than 2 among the clinical criteria, sir. Total more than 4, sir, out of slick criteria, sir.
Anybody in the other students who are attending who can enumerate the criteria, please turn on the mic and you can talk. Or raise your hand. No one? Okay, so I think that you can just read up, because these criteria are always changing. What I remember is the WHO criteria. So there are new EULAR criteria and other. You just read up. Okay, I'm not. I don't want to give you misinformation. So you just read up those criteria. Dr. Sham, anything else, or should we close down?
Yeah, I think we should close now.
Okay. Okay then.
Thank you, sir.
Okay. Thanks everyone. Okay.
Thank you so much, faculty. Thank you.
Thank you. Okay.